If we can identify patients who are more likely to benefit from single agent therapy, then we can tackle those patients who are not going to respond and how we can approach them differently with newer types of combinations. The landscape of lung cancer has been really transformative over the last year to 2 years. We now have 3 PD-1, PD-L1 agents that have shown survival benefit compared to second-line chemotherapy in non-small cell lung cancer. That includes atezolizumab, pembrolizumab, and nivolumab. We now have actually long-term data showing about a 18% 5-year survival, showing that there's a subset that really can have durable benefit to these therapies. We've also seen some exciting potential for combinations of agents. And of course, one of the most important observations was if you select patients based on PD-L1 expression, in the first-line setting, pembrolizumab was clearly superior to chemotherapy, not just in response, progression-free survival, but overall survival. So that really changed how we approached lung cancer in terms of having an immunotherapy option instead of chemotherapy in the first-line setting. We know these drugs, these PD-1, PD-L1 antibodies can be highly effective in 15 to 20% of patients with non-small cell lung cancer. We are starting to better understand who is and who is less likely to benefit from these agents. For example, we know that patients who are never smokers, who have an EGFR mutation, they tend to be less mutationally complex, less DNA damaged, so they don't react to the immune system as well. So those patients do respond less well to immunotherapy. Along those lines, trying to identify patients more precisely who can benefit from immunotherapy is through mutational analysis. Now seeing data with atezolizumab as well as more recently with nivolumab, that if we separate patients based on how many mutations they have, that can be a very good biomarker, particularly in concert with PD-L1, to really select patients who are likely to benefit. In the very near future, we're going to see a fair amount of data around chemotherapy combinations. The most mature phase 3 trials with chemotherapy combinations are combinations with atezolizumab with chemotherapy, as well as pembrolizumab with chemotherapy. So as we see that data, we may be able to identify those patients who may be more likely to benefit from chemotherapy combinations. Also in the near future, durvalumab and tremelimumab, PD-L1 and CTLA-4 is really the most mature immunotherapy combination data. Hopefully we'll see some encouraging activity in that phase 3 trial as well.